And it is with my deep pleasure, I welcome Dr. Daren Heyland to speak to us today about advanced care planning. Welcome, Dr. Heyland.
Thank you. Thank you very much. It's a pleasure to be back. I've done this presentation before for Caregivers Alberta. First thing you need to know about me is I'm a family caregiver myself. And although my professional designation is from Queen's University in Kingston, Ontario, I'm actually an Albertan living in Lethbridge currently and benefiting from the services of Caregivers Alberta. And so I'm happy to contribute in any way I can. COVID certainly was sort of a wake-up call for many of us to think ahead and plan ahead for our medical care if we were to get a serious illness such as COVID pneumonia. Gratefully, COVID has dissipated, but there still are serious illnesses that can confront people. And whilst the call is to really do your end-of-life planning, and perhaps you came on this webinar thinking that's what this topic would be about, I'm here to say, as I said in the Globe and Mail through COVID, that it's not about end-of-life planning. It's about advanced serious illness planning. It's about thinking ahead and planning ahead what kind of medical treatments might be right for you if you are seriously ill. And maybe you're here as a caregiver and it's less about what kind of medical treatments might be right for you, but maybe for your loved one who you're caregiving for. What's the plan if they get seriously ill? And 95% of the time when an individual becomes seriously ill, they're not able to voice for themselves. They're not able to participate in decision-making. So a big part of this planning is the naming and capacitating of someone to represent them. So the voice of that individual is heard. And so that's the ground that I'd like to cover today. I'll say a little bit more by way of introduction. I'll talk a little bit about the research that we've been doing that has highlighted problems that center around communication and decision-making error, which has led me to shift away from what is traditionally known as advanced care planning or end-of-life planning to this concept of advanced serious illness planning. And then I'll introduce you to a Plan Well guide and hopefully engage you to go off and do your advanced serious illness planning. I'm a critical care doctor by background. My lived experience is working in an ICU, such as I'm showing you a picture here. And for those of you who perhaps have been in an ICU or had a loved one in the ICU, you probably get why this is so important, because there's tough decisions to be made. They have life and death consequences. And unfortunately, as I mentioned, patients are too sick to participate in that decision making. And so we are always collaring a family member to participate in that end of life decision making. And my lived experience in the research shows that those family members who are co-opted into this role unexpectedly many times are ill prepared for that role and frequently suffer not only stress in the moment, but later regret, guilt, even post-traumatic stress disorder because of what went on, in the acuteness of that setting where they had to make a life and death decision. I'll never forget the one woman who called me 6 months or so after she and I had to make a very quick decision about using or not using life-sustaining treatments and admitting her husband to the ICU. And in a matter of minutes, we had to decide not to. And we kept her husband comfortable. He passed away within minutes. And I went on to the next patient and never thought about it again until 6 months later, she calls me and she says, Dr. Heyland, and reminded me of the scenario. Dr. Heyland, did we do the right thing? And so here's a woman grieving and feeling burden because of questioning the decision that we made acutely. And had those plans been in place and she was simply representing the voice of her husband, she wouldn't have had to suffer like that. Here's another anecdote from CBC last year, where a gentleman was describing his burden, his suffering as a consequence of being involved in, life and death decision making around his father. And what I found so extraordinary about this story was this was a 94-year-old man who the son had to make this life and death decision, and consequently is suffering. And you'd think that through 94 years, there would have been multiple opportunities for him to have shared with his son or talk to his doctors, or create an advanced serious illness plan. So a lost opportunity results in suffering for not only the patient who gets the wrong medical care, but for that family member who's left sort of in that role or that responsibility of making those life and death decisions. And so really what I want to stress is the importance of doing this planning so that you not be a burden on those that we leave behind. And I'll never forget a story of a good friend who showed up to visit her mother at home. Mother was very dependent on assistance and had caregivers coming in. And as she showed up at her house one day, the ambulance attendants were there, and someone had activated a 911 response. And as the surrogate decision maker, she was foisted into that immediate role of what is the game plan here, working with the ambulance attendants and subsequently the doctors, and found herself ill prepared. And so when I met Yolanda, her desire was to really engage in advanced serious illness planning so as not to be, a burden on her children. Now, many of you maybe don't have that lived experience with serious illness decision making, whereas so you don't really know what I'm talking about. And so I want to flag that on our website we have what we created a virtual reality, a 4-minute video showing a scenario of serious illness decision making where our family members are grieving at the stress of making that end of life or that serious illness decision making. And so I refer you to our website. You'll see on the tab virtual reality ICU decision making. You can watch that without a headset. You can just watch it in a 2D way and get a sense of what we're talking about. But if you are a gamer and have a VR headset, you can download it in the Oculus app and watch it in an immersive environment to really get a sense of what serious illness decision making is and the stress that people feel when they're unprepared or ill prepared rather for that experience. And so one of the key messages, and this sort of cuts across many aspects or dimensions of family caregiving, is the more that you can sort of think ahead and plan ahead, the more likely you are to gather resources, be informed, make better decisions, put better plans in place, and develop plans, plan B and plan C, versus if you're reactive in nature and you don't put plans in place and then things happen. It's not the time to fix a leaky roof when it's raining. It's not the time to talk about and make good decisions about serious illness management when you're seriously ill. Your voice won't be heard or your loved one's voice will be unknown. And so we've got to work upstream and engage in proactive serious illness management or planning if we're going to have success with that. It's not just about relieving the burden on family members either, or the burden on yourself if you're a family caregiver. It's also about getting the medical care that's right for the person. Our research has documented a lot of medical error, and I'm not trying to besmirch our healthcare system, but you can appreciate, particularly in a post-COVID world, how stressed our system is. Consequently, there are mistakes or gaps or problems in getting the right care to the right person at the right time. And so the more you can shift into managing that yourself, advocating for self, the better off it will go for you. For example, here's a woman who I wrote in the local paper about this matter of serious illness planning. And she wrote back and said, it's, a year ago, my husband died. He was 78. I am one of those who's still suffering from having to see a loved one having to endure the pain of mechanical ventilation when he should have been offered palliative care. Someone in emergency should have known that we needed this based on the medical evidence and his history of many admissions in the previous year. A couple of notable things about that anecdote. One, it's a year later and she's still suffering, still grieving, so much so that she penned a letter to me and expressed, her concerns. But number two, do you interpret how passive she was as she and her husband went into the healthcare system? Someone else should have known this. And if there's one message that I could convey, it's to shift you from being passive to actively managing your health and your health journey. And I know you say, well, we're just lay people. What do we know? How do we navigate that? Well, the more you know, the more you engage. And this is what we try and do at Plan Will Guide, is educate, engage, and empower you to navigate your own illness journey. The better off your experience will be. Some of you might be thinking, well, gosh, if this is such an important topic, why doesn't my doctor bring it up? Or why doesn't my family doctor bring it up? And then you're thinking, well, I don't have a family doctor, so how am I ever going to have this conversation with them? Well, not to worry about that. And I'll address the family doctor shortage later. But the point is, we asked ourselves this same question, why doesn't the doctor bring it up? We surveyed hundreds of doctors and nurses throughout hospitals in Canada who frequently care for older patients on hospital wards. And we asked patients themselves, had the doctor talk to them about their care plan, their wishes for going to ICU and receiving life-sustaining treatments. And only 1 in 3 of the older persons on hospital wards acknowledged that a healthcare professional had spoken to them. And when we spent an hour getting to know them and eliciting their values and preferences for going to the ICU, and then we compared that to the medical order on the chart, it only agreed 1 in 3 times. So that's kind of a shocking statistic, that you have a 1 in 3 chance of getting the medical care that's right for you when you're an older, vulnerable person in our healthcare system. And this is a communication decision-making error. So then we go back to these doctors and nurses and saying, hey, why don't you talk to your older persons and or their families, to make better decisions, to mitigate the risk of these kinds of errors? And what I'm showing you is a long list of reasons why they don't engage, and the rating of importance, or how important are these various reasons. I apologize if the font's too small to see on your screen, but they're the top cluster of reasons why doctors and nurses don't engage older persons and their families around discussing going to an ICU or receiving, ICU treatments, is they feel that they're not prepared. They're not prepared to have these discussions. They don't know enough. They don't accept enough. And so it's another way of saying, I just don't have the time and the energy, because I'm busy with 30 other patients, to sit down and prepare them and help them get ready to have, these meaningful discussions with me about going to an ICU or not. And so again, I put that responsibility back on you as citizens to get more informed. And here's a slide from an Australian government where, as you can appreciate, in Australia, they have lots of natural disasters. And so they're trying to say, hey, be informed about what kinds of disasters might occur and what you might do in response to that. And what I'm trying to say is, hey, be informed of what kind of serious illnesses might occur in our lives naturally, and be informed and prepared to deal with that. And so the more informed, the more proactive you are in managing your health journey, the better off it will go for you. Now, at this point, I make a very important caveat that as much as I'm trying to coach you to put your hands on the wheel and drive the car or steer the ship, and become the captain of that ship, you're not the ruler of the sea. And so there may be things beyond your control. And I'm sure you've experienced that already as a family caregiver. So we can't control everything, but to the extent that we can control things and plan for things and gather resources for things, this would be an important step for you to lean into. Now, some of you might be thinking, or maybe your loved one is thinking, and doesn't want to talk about it because their family knows me and they will know what's right by me. And I hear that a lot, that people fail to engage in this kind of planning because their family knows them. they'll make the right decisions. And now on the slide, there's a quote from a critical care doctor who says, I'm talking to families all the time and they don't know, even though they love that individual and they know them well, they don't know exactly how to answer my questions. And so they feel stress and anxiety when they're put into that role of answering questions that have life and death implications. So it's not a challenge on whether your family loves you or likes you or even talks to you, but you still need to go through this planning and record your answers in a way that critical care doctors like me will find useful. Now, some of you might be thinking, well, wait a minute. I went to the lawyer, I filled out those forms, I've done my medical planning. And I just, want you to think about the sensibility of going to a lawyer to do health planning. And I've given lots of talks and engaged lots of lawyers and legal societies trying to get them out of the health planning space. And unfortunately, the way laws are created and the way forms, such as the personal directive, is created, it enables lawyers to record your instructions for health planning. And typically, the language is under conditions of certainty. So things like, when I am dying, this is what I want, or this is what I don't want. And that gets written in your personal directive. You give that instruction to a lawyer, it gets written in your personal directive. Or maybe it says something like, when I am in this persistent vegetative state, just pull the plug or just keep me comfortable, or whatever that instruction is. And so that gets accomplished and you leave the lawyer's office feeling like you've done your health planning. And unfortunately, I'm here to say that that's not only useless, but it's potentially harmful, because what's left is us as doctors and your family members trying to reinterpret what that saying meant in the context of serious illness, where when you get a COVID pneumonia or when you get hit by a bus, I don't know if this is your dying episode. You could die if I don't intervene, but if I intervene as a critical care doctor, I might be able to recover you and recover you in a good shape. And so what do I do at the point where I have to make decisions under conditions of uncertainty? I'm not sure you're going to die. You could recover. And that's really the aegis or the meaning behind serious illness and serious illness planning. And so I created a website where I coach people through a serious illness planning exercise where it fits the clinical scenario. We're not talking about end of life care. I go through great lengths to explain, this is not terminal or end of life planning. This is serious illness planning, where you could die, but there's a probability that you could recover. We're making decisions when we're unsure about what your final outcome is. Now, many of you, I know, are thinking under those conditions of uncertainty. When I ask you, well, what kind of treatments might be right for you when you're seriously ill, you're thinking, well, that depends. It depends on how I turn out, right? If I'm going to turn out good, I'd want you to do everything. If I'm going to turn out poorly, I'd want you to not, just keep me comfortable. And again, I'm in this unfortunate position of saying at the point where I start this journey with you using life-sustaining treatments, I don't know for sure how you're going to turn out. We have to make decisions under uncertainty. And an illustration of that is, the weather report. And I hear there was some thunder showers and storms in at least northern Alberta and in Edmonton today. And I imagine the weather report went something like, there's a 70% probability of thunder showers and lightning today, and rain, probability of rain. Now that didn't say 100% certainty, or maybe it did, but whatever, you know what I mean. There's a probabilistic statement in a weather report, 60% probability of rain, and you still have to decide, are you going to modify your activities? Are you going to go out? Are you going to carry an umbrella? And so we move forward with decision-making under conditions of uncertainty, not sure how it's going to turn out, not sure if it's going to rain, but I got my umbrella just in case. More to the point, which is perhaps different than what lawyers or traditional advanced care planners do, is that we do not advocate that you make medical decisions in advance. but rather that you prepare yourself and your representative, the agent or the person who's going to speak for you, with a knowledge of your values and your preferences. And on Plan Well Guide, we educate people as to this is how medical decisions are made. In the future, when you're seriously ill, a doctor will talk to you and tell you about your disease and the possible treatments and risks and benefits and possible outcomes of those treatment options. And what he or she will want to know from you are your values and your preferences. And together, that magic happens, and what we call shared decision-making, medical decisions are made, and you get the medical treatment that's right for you. So we're not advocating instructional directives or any advanced health decision-making, but rather preparing for future decision-making. It's worth reflecting on your capacity and knowledge of these different medical treatments and how comfortable you feel participating in medical decision-making, or how informed are you. We know from surveys that most people get their medical information from TV. CPR, or cardiopulmonary resuscitation, is a good example of an end-of-life treatment, and TV portrays that very inaccurately. And people have this sense that they can just get a few chest compressions or a few breaths in the mouth, and then they're up and running and chasing someone again. And that's not the reality of the experience in hospitals, where we resuscitate people all the time. And we elicit from people their preference for being resuscitated, yes or no. I imagine some of you have witnessed that questioning, where a doctor usually says to someone, if your heart stops, do you want us to revive you? As if you know exactly what's involved in being revived. And in fact, we surveyed older persons in hospitals across Canada, asking them, what do you understand about this process of being revived or receiving CPR or cardiopulmonary resuscitation? And only 2% of the participants knew the details of what CPR included, including ended up being, in an ICU, on life supports. We also asked, well, out of 100 people like you, if your heart were to stop and you were to get resuscitated, what are your chances of being discharged home? That'd be a good thing, is to make it to not just being alive, but alive and being able to discharge home. And 2/3 of the respondents didn't have a clue. The right answer is 10% or less. So 3% of respondents who had a CPR order on their chart, they signed up for something that they know nothing about. So I'm just, again, highlighting the quality of decision-making that occurs today in hospitals around the world, not just Canada, and why we invested ourselves into creating the first decision aid that explains what is CPR, what is ICU medicine, what is medical care, what is comfort care. So there's a lot of content there on Plan Well Guide that helps people understand the nature of these treatments, their possible risks and benefits and outcomes, including a 7-minute video decision aid specifically around CPR. So we encourage you to get educated, get informed, and then we go through a process of trying to elicit your values, because we want to offer medical treatments that are grounded or based in what's important to you. And frequently, when I get into these values conversations with patients or their family members, and I ask things like, well, have you ever talked about this as a family or with your loved one? And sometimes they say no. More frequently, they say no. But sometimes they say, oh, yes, we talked about it. And as the quote on the slide says, my husband said that if you were in a coma, he'd never want to be kept alive on machines. As if that's the sum and total of the conversation. And so unfortunately, I'm left in a position of trying to reinterpret, with your assistance, what that means in the context of the medical problem that your husband has, and whether the use or the continued use of life-sustaining treatments is meritorious in that case. And so we've tried to, and we've done research to try and nail down what are the best questions and answers to said questions that are most informative to critical care doctors like myself. And so we've landed here. This is research informed, what questions people need to answer in their own voice to inform the future doctors who will be looking after them or family members who will be representing them. And so just think about this, yourself, given your current health state. So we're not talking about tomorrow when you have cancer or the day after that when you get hit by a bus, but rather today, if you were to get hit by a bus, what would be your willingness to accept the risks of ICU resuscitation and ICU treatments? And remember, this is now after you've gone through our decision aid and you understand what ICU treatments are, what their risks and benefits are. So you're informed, and then we ask you to grade your willingness from very willing to put up with that burden of care to not very willing. And the second question is, what's your willingness to accept a significant reduction in your quality of life or your ability to look after yourself? Because that's the consequence of ICU treatments. You may be alive, but you may be alive in a reduced health state. So those are the two most important questions that people need to reflect on and answer. And what we've innovated is we've taken those questions, made them the X and Y axis on a grid, and the answers to your questions, if we transect or bisect those answers, it sort of co-locates for us what we think the medical treatment might be right for you. Now, why this is important is because it makes the decision-making very transparent and very reproducible. Right now, you go into an emergency room or into an ICU setting, you talk to a doctor, and if you say something like, my husband, he didn't want to be kept alive on a machine when he's in a coma, because that's the sum and total of your advanced care planning, then that doctor has to interpret that. And it happens inside his head, and outside of him or herself then will come an order for the use or non-use of life-sustaining treatments. Well, that's a very non-transparent, very unreliable, irreproducible process that results in medical error. And if you get a different doctor on a different time of day, you might get a different decision. And so how do we improve the quality of decision-making? We make it transparent, we make it reliable. So that's what Plan Well Guide does. It also has a second approach at helping you think through what medical treatments might be right for you by this graphic, where we sort of categorize 6 different levels of care, from full intensive care, live at all costs, all the way down to, hey, I'm ready to go. Just let me go, keep me comfortable. And then there's different levels in between. And so we use lay language, we use imagery, we use very descriptive technical language, just to try and help people localize themselves. This is where I'm at. This is what I think is right for myself. And so that process that I just briefly explained is found in the Guide to Exploring on our website, planwellguide.com. It's free, and it helps people find their voice, their authentic values, and informed treatment preferences. There's another dimension to advanced serious illness planning, and that is, okay, you may be sick, you may end up in an ICU, or even if you don't end up in ICU, if you survive your serious illness, but now you're incapacitated, say you had a stroke or you developed dementia, have a brain injury, you're not able to look after yourself. So there's going to be a need for people to make personal care decisions. Where you live, what kind of clothes you wear, what you eat, who has access to your medical records, who visits you. And regrettably, there's a lot of family conflict, around these personal care decisions, because people in the family feel differently about what should be right for mom or dad, etc. All of that conflict could be avoided by better upstream planning. And so we're trying to change the way people plan for personal care by having them reflect extensively on the kinds of care decisions that will need to be made from a personal care point of view, and put those down in a set of instructions in the context of our planning software. And so the Guide to Equipping, and here, this one's not free, there's a cost to it, because we produce what is known as the Dear Representative letter, where we give and we equip that agent or that person that's going to represent you with the medical care instructions, the personal care instructions, as well as the legal document that enables them to be your representative. That's called a personal directive here in Alberta. And the other problem we're trying to solve with that guide is the accessibility of those documents, because frequently they're in a filing cabinet in a folder at home. And if you're traveling on your way up to Edmonton and get hit by a bus and you end up in an emergency room somewhere and an ER doc needs to have access to that, that's a barrier, right? Because it'll take time that people don't have to access those planning documents. I'm very familiar with the green sleeve, and I know they're on your refrigerator at home, but if you're not at home, then there's an accessibility problem. And so we provide our users with a wallet card with a QR code so that if you give that card to someone, or if you're found as a John Doe and the medical personnel will know to look in your wallet, if they see a card like that, they'll launch into the cloud where you're stored your planning documents, and you can access them, and they'll know at an instant, what the instructions are. So that's the guide to equipping the representative to represent you and make sure that those planning documents are accessible. There's one other guide that I'll make brief reference to, and that is the guide to entrusting, where you normally go to a lawyer to prepare someone else to make the financial decisions for yourself if you are incapacitated. And to be honest, that's a very perfunctory process where you give a name to a lawyer, he fills out a form, there's a lot of legal language, but in the end, it's given that power of attorney has the ability to manage your finances if you are incapacitated, if you are vulnerable. And regrettably, what we see in the courts, or what we see happening real time, is a lot of family conflict again. And really what it comes down to is, what were the wishes of the individual and how did they express those? And if you don't have it written down, then there's fighting between one member of the family who says X and another member of family that says Y. So better upstream planning will reduce the risk of family conflict. In the area of financial management, a lot of the abuse or misuse of funds of vulnerable people happens because a family member has been given that trust without adequate instructions and without adequate oversight. And so the guide to entrusting educates the user through that process, helps them pick the right individual, but also set up those instructions and oversight mechanisms to minimize the risk of misuse or abuse of funds. So we don't draft power of attorney for finances, but we do draft a Dear Lawyer letter for which you can go to your lawyer and get that power of attorney for finances with those extra steps in place to minimize the risk of conflict or misunderstanding or even misuse of funds. So on this slide, I'm just showing you the actual tangible outputs of engaging in advanced serious illness planning with the Guide to Exploring, the Guide to Equipping, and the Guide to Entrusting. The Guide to Exploring gives you the Dear Doctor letter, so you've got a script to follow with your doctor. No, it doesn't have to be your family doctor. Your family doctor is not going to be the one that treats you when you're seriously ill. It'll be some emergency room physician, some critical care physician. So it's not that important that you discuss this with your family doctor, unless, of course, you have questions. And if you can't access a family doctor, we have some getting help features on our website where you can book some consultations at a charge for us to be able to talk you through, your plans. So Dear Doctor is the output of the Guide to Exploring. The Guide to Equipping, you get the Dear Representative letter plus the personal directive. You may say, I already have a personal directive. Yes, you do. That personal directive probably has legal language in there about if I am dying, this is what I want or I don't want. And we don't want the prior personal directive to conflict with the new personal directive. And so working with the Legal Society of Alberta, we've removed the part on the personal directive, the government form, that has anything to do with health planning. And we've inserted this clause that I'm showing you here on the slide, which basically just says the instructions by which the agent should operate to represent me are found in the Dear Representative letter. And so the Dear Representative letter and the personal directive, work together. I'm going to make the same point, but now I'm going to show you for the Alberta context, what being optimally prepared looks like for serious illness. That dark thing on the back is your green sleeve. And yes, if you have a green sleeve, that's great. If you put it on the fridge, that's awesome. But remember my comment about it's not going to be accessible if you're driving up to Edmonton and have your serious illness. Nevertheless, in that green sleeve, you put your personal directive, your dear representative letter, and if and only if you're in that final stage of life and heading towards the finish line, would you need to fill out a goals of care designation form. You might have other considerations around insurance products, contingency funds, funeral planning, etc. Save that for another day, another topic. My focus is really on preparing your thoughts and your plans for the medical care and equipping your loved one to know what they are, having the documentation to support that. So by spending some time and maybe a little bit of money in advanced serious illness planning, you're going to benefit a lot, taking comfort that you're adequately prepared, your voice will be heard, you've eased the burden, on your family, and you're more likely to get the medical care that's right for you. I'm just closing here, and I wanted to, just share an anecdote from a user, someone that came through our planning process, actually attended an in-person seminar in Southern Alberta that I was doing. And her and her husband went through the planning process, spoke to their family, developed their advanced serious illness plans. And then, wow, who would have known that just a few months later, the poor husband fell, bonked his head, and sustained a life-threatening brain injury. And he was transferred to Calgary for some emergency care. And a few days later, the woman reports that she was talking to the neurosurgeon and having to make a decision to continue life-sustaining treatments and aggressive brain surgery, or just focus on, comfort measures with an understanding that he would pass away. And she says, when the doctors approached me to make decisions on Gary's behalf, I didn't want to stress the stress of taking that responsibility all by myself. And I was so grateful that I heard Gary's voice and I was able to communicate his wishes to the doctor. The planning helped me understand what he would have wanted. And because he'd already discussed those wishes with our children, they also understood what was best to do. I like this next concept. I feel it's so important to talk about these things. You don't want to feel guilty about what was done. You want to feel like you've honored your loved one's last wishes. So those are difficult decisions to make at the end of life. And it will be difficult no matter how much planning you've done. But if you can cherish the fact that you honored their wishes rather than feel guilty or wonder about whether you did the right thing, that's key to this whole process. And so one couple summary thoughts. I think I've tried to communicate throughout this presentation that people need to shift from perhaps being a little more from being passive to being a little bit more in charge, seeing themselves as the captain of their own ship, or quarterbacking it for a loved one in the context of family caregiving. And that means getting informed and engaging in proactive planning. And that's what Plan Will Guide is. We're a medical proactive life management company that we want to help people in their life journey wherever they're at. We aim to help people realize a high quality of life, a long life, and support them through their serious illness and help them end well and leave a positive legacy behind. So I've just been talking about these 3 guides here today, advanced serious illness planning guides, but if you do go on our website, you will see that we have other guides to offer at different stages of that life journey. And so as a final request, I'd love to invite you to engage in advanced serious illness planning. The first guide is free. If you don't like it, if it's too complex, if it's too negative of a feeling for you, I'd love to get some feedback on that and how we can soften that. But if you do like it, I encourage you to complete all 3 guides and promote it amongst your family and friends, and particularly those that you care for.